Welcome to our first lecture of a series of lectures that will cover hypercortisolism. In this series, we will take you through a diagnostic approach to hypercortisolism, and then we will discuss the different categories of hypercortisolism. By that I mean pituitary Cushing's, adrenals, and ectopic, and also iatrogenic Cushing's. The first thing with respect to Cushing diagnosis is the first thing we have to agree on is it can be a very challenging to the clinician to establish a diagnosis for a lot of reasons. One of them is the fact that the disease phenotype is quite heterogeneous. It can vary in severity and in clinical presentation from subclinical or mild Cushing's with hardly any signs except trankylobesity to a florid Cushing's. It can even mimic polycystic ovarian syndrome. The other challenge we have is the fact that the tests we use to establish the diagnosis have a lot of caveats and variable sensitivity and specificity. Hence, we need more than one test to establish the diagnosis. So to start with, looking at the patient history, often but not always, these patients would have recurrent infections, or even unprovoked deep venous thrombosis. The numbers you see on the slide is derived from a small case series, so they are not no way as accurate. But by and large, I don't want you to remember these numbers, but what I like you to remember that maybe 1 in 2 patients with Cushing will have hyperglycemia. 1 in 2 of them will have osteoporosis or osteopenia, preferentially lumbar osteoporosis. They're more likely to have hypertension, more likely to have menstrual irregularities and depression, but the vast majority of them will have lethargy. They don't feel well. Cortisol is a stress hormone, and could you imagine yourself living in a biochemical stressful status? So they always report that they're not feeling well. The vast majority of them will have a plethoric phase, trankylobesity, doses of called fat pad in about half of them. Proximal muscle atrophy takes time to develop and usually in severe Cushing's. Same as the dermal signs in terms of easy bruisings and violacea stria. Hirsutism as well. And what I usually do, I ask, when I suspect a patient with Cushing, I ask them to bring an old photo to compare. And you could see, often you could see a striking difference between the old photo and the recent clinical phenotype. Again, these signs need time to develop, and therefore you would not find it in acute hypercortisolemia. And by that I mean ectopic Cushing's. Often I got asked, how would you differentiate between someone with morbid obesity and Cushing's? And my usual answer is we all have seen someone with Cushingoid features in our practice. All what you need to do is to look in your database for someone who's been using steroids for a long time, patient with COPD and rheumatoid arthritis and so forth and so on. So this is what patient with Cushing disease look like. How do we screen when we investigate a case of Cushing's? Well, the principal diagnostic approach in endocrine. If you're doubting, if you're investigating for excess hormone, then you need to suppress it. If you investigating a hormone deficiency, then you need to stimulate it. And the other principle is you need to choose someone with reasonable pretest probability. Those who have low pretest probability will often end up with false positive results. And that can be troubling both for the clinician and for the patients. So once you get one positive test, you're obliged to follow on it with another test or more tests. Some of them are invasive and costly as well, particularly in countries where there's no public health care cover, let alone the anxiety the patient would have to go through whilst doing these tests and waiting for their results. So basically, if you have clinical doubt when you're seeing a case, then by all means you need to test. If you don't have any clinical doubts, then maybe you shouldn't be tested just for the sake of doing the test as part of the theoretical differential diagnosis. And the diagnostic approach, as I just briefly mentioned, is by suppression test and or other test modality, which we will talk about in the following slides. However, we need more than one positive test and preferably 2 different tests to establish the diagnosis. And once you establish the biochemical diagnosis, then we move to the next step, which is localizing the source. So we should avoid any imaging until and unless the diagnosis has been established. The exception to this algorithm is the increasing number of cases we see with adrenal incidentallomas, where the patient has a CT abdomen for whatever reason, looking at abdominal pain, and whilst they're being investigated for abdominal pain or kidney stones and so forth and so on, they found an adrenal incidentalloma. And all the adrenal incidentalloma need to be investigated for Cushing's. And we will have a designated lecture about adrenal incidentalloma in due course. Now, the first common mistake that we see in our practice is someone who would check fasting cortisol level, looking for elevated cortisol to rule in Cushing's, or normal cortisol to rule out Cushing's. Well, in this slide, it just shows you on the left part of the panel how a person with a Cushing can have low cortisol on one occasion, which drops down to the normal reference range. On the right side of the panel, however, a person with a normal, with a non-Cushingioid person could have a high cortisol level that could reach levels that of person with Cushing's. Therefore, fasting cortisol is perhaps a good triage test to rule out adrenal insufficiency, but it has very limited use when we come to the investigation of Cushing's. The first test we do to establish the diagnosis is the 1 milligram dexamethasone suppression test. Normally, in a normal person, the cortisol was suppressed to less than 50 nanomole per liter, and this will comfortably rules out any autonomous hypercortisolism, with the exceptions of cyclical Cushing's. Now, I'll put the slide just to show you that even these patients were all suppressed to under 50 nanomole, but the risk of diabetes is graded towards the higher quintile of the results. So even within the normal reference range, there is still risk of diabetes. Now, what's define a positive test? When the cortisol failed to suppress below 138 nanomole per liter. Again, you need more than one determination. And in real life, cases with fluoride cushion, often they fail to suppress below 400 nanomole per liter. With these results, it's very unlikely. Well, it's more likely that you're dealing with a bona fide true result. And as I said, often patients with fluoride cushion tend to have high post-exercise suppression cortisol levels. Now, this slide just to show you where we derived this normality cutoff from. And the panel showed both in women and men the visceral fat to total body fat ratio. It tends to be unchanged for when a person suppresses their cortisol to less than 1.8 microgram per deciliter, and it tends to go higher afterward. However, beyond 138 nanomole per liter, the ratio will plateau at a higher level. So this is where we got the cutoff. Between 1.8 and 5 microgram is a gray area and often represent a mild form of Cushing. We call it subclinical. And this is a study showed the false negative rate for 1 milligram dextrose suppression below 50 nanomole per liter is 5%. The false positive, however, is about 30%. And again, because of the representation in the range between 50 and 138 nanomole per liter. Now, the downside of this ambulatory test is the fact there's a lot of drug-drug interactions, a lot of enzymes that induce the cytochrome P450 pathway that catalyzes the dexamethasone, and that's 3A4 subpathway. Enzyme inducers, particularly anti-epileptic medication, as you can see, and many other medications, will lead to false positive because of the less bioavailability of the dexamethasone overnight. Vice versa, if you have an enzyme inhibitors, you're more likely to get false negative. And I put this link to take you through a long list of medication. I don't expect you to memorize them, but when you are planning to do this test, please have a look at the patient medication list and look it up on your with your data, basically to see if the medication he or she has could have an impact on the dexamethasone metabolism. And if it does, then you might need to change them temporarily while you're doing the test. Clearly, if someone is on anti-epileptic medication, you do need to consult with the patient's neurologist before you change his or her anti-epileptic regimen. The next test we'll look into is salivary cortisol. This is has been gaining ground over the last few years. It does measure the free cortisol, so it doesn't get affected by the estrogen status. So women who are on the pills, you can test for them. It does, however, have a wide range of intra-individual variability, and hence you need more than one determination. It's certainly a lot better than 24-hour urine free cortisol in detecting mild hypercortisolism, but it's not as accurate as the midnight serum cortisol, but it's rather more convenient for the patient just to give them a small canister to collect the saliva late at night than to send them to a pathology unit at midnight to take a blood sample. You can get a false positive result with smokers. We do tell the patient not to brush their teeth that evening and not to avoid have a late night meal, and even try to avoid any psychological stress. This test is not reliable in any person who works night shifts because of the reverse sleep-awake cycle. What I really like about this test is the fact that it can rule out pseudo-Cushing's very comfortably. And by that I mean obesity-related pseudo-Cushing's. As you could see from the panel, the left side is with salivary cortisol levels in Cushing's patients, while next to it is patient with pseudo-Cushing, and you could tell that the salivary cortisol level is a lot higher. Now, you have to be very careful when you interpret the result. We do need to know our pathology and what sort of machine they use to assess the salivary cortisol. The radioimmunoassays are more likely to read higher than the tandem mass spectrometry, and the latter is a lot more accurate. The radioimmunoassay, generally speaking, in any other modalities or platform, they do measure higher than the chromatography and tandem mass spectrometry. And we expect it to be defunct in the near future. This is another study that showed another downside of the late night salivary cortisol. And I hope you appreciate in 45 or almost half of the patients who have diabetes and hypertension over the age of 60 will have a raised salivary cortisol. So it's probably not the best to check for or to rule out Cushing's in an elderly person who has diabetes, particularly poorly controlled diabetes and hypertension. We still do it, but we have to bear in mind the possibility of false positive. And I can tell you now, if it's false positive, it tends to be mildly elevated as opposed to significantly elevated. The other test we have to assess for excess cortisol secretions, 24-hour urine collection. It's a very cumbersome test. The patient has to collect the urine over 24 hours and they have to bring it back to the lab. The defining normal is more than 4 times upper normal range. It has to be at least 2 times the upper normal range. The higher the cortisol in the urine, the more likely you're dealing with a true hypercortisolism. The downside, this test has a lot of caveats. One of them is the wide intra-individual variation, and I could show you in the slide. These two circulated results are for the same person who did not have Cushing's. One reading was very high and the other reading was low normal. The false negative result of the test is not very accurate when you have a patient with chronic kidney disease. And sometimes we have to resort to the cortisol creatinine ratio to have indirectly measure the hypercortisolemia. This test is almost useless for someone with mild Cushing's. On the other side, false positive with heavy alcohol abuse, both stress, be it mental or physical, can cause some degree of increased urinary cortisol. Poorly controlled diabetes, patient on fenofibrate or sodium valproate will have a false high result, and again pseudo Cushing's. polyuria is another common problem as it leads to false high urinary cortisol. Patients, particularly who are severely depressed or psychotic, they tend to have psychogenic polydipsia. And so you do need to look into the total amount of urine volume. If it's more than 4 liters, then you're more likely to deal with false high result. As you could see from this panel, this is for normal volunteers, and you could tell that as the urine volume increased, the urine cortisol increased as well. So in these cases, we could look into the urine cortisol creatinine ratio. But then again, this ratio is a derived formula, it's an indirect way, and it's not very reliable. Now, I put this slide just to show you with subclinical Cushing the difference between 24-hour urine and late-night salivary cortisol. The panel on the left represents 24-hour urine cortisol. These patients have a surgically proven Cushing syndrome, and the pre-op test showed normal 24-hour urine cortisol in the vast majority of them, while in the late-night salivary cortisol showed most of them has scored positive result. And this is just to confirm the fact that in mild Cushing's, 24-hour urinary cortisol is actually not the test of choice, and often can be false normal. So after we establish the diagnosis with the previous 2 or more tests, we move into the next step, which is localizations. Biochemical localization, we look at the ACTH. If we look, so in cases of adrenal Cushing's, the ACTH will be under 10. If it's pituitary or ectopic, it will be more than 20. And bear in mind that with ectopic Cushing tend to be a bit more severe, and ACTH can be really high. The gray area is when the ACTH between 10 and 20. And that's when we use the DHEAS, which I'll refer to in the next slides. We do 8 milligram dexamethasone suppression test overnight to differentiate between pituitary and ectopic. So if you have a high ACTH repeatedly, you cannot rely on one determination because of the pulsatile nature of corticotropins. Then you could do a test, the 8 milligram DEXA suppression test. Now this is not very sensitive again, but it's very cheap, it's affordable, it's ambulatory, it's a lot easier to do than the IPSS. If it's suppressed more than 50%, this is more likely to be from the pituitary, and if it doesn't suppress, then it's more than 50% of the baseline, then this is likely to be ectopic. Serum potassium is a very important electrolyte when you're trying to localize ACTH dependent Cushing's. It's often low in ectopic Cushing's. Now, as I said, ACTH ectopic Cushing tend to be severe and ACTH tend to be high, and the hypokalemia tend to be refractory. However, that's in the paraneoplastic ectopic Cushing. But with the carcinoid can secrete ACTH and they tend to be mild. That's probably account for why the 8 milligram DEXA suppression can suppress to lower than 50, the cortisol to lower than 50% of baseline in someone with carcinoid-related ectopic Cushing. DHEAS is adrenal androgen. It's manufactured under the influence of the corticotropins. The DHEAS has a longer half-life than DHEA, and that's why and therefore it's more reliable to measure. If it's low, then this may well reflect adrenal Cushing's. If it's high, this may reflect an pituitary or ectopic Cushing's. We move then from there to localization with imaging. You have to bear in mind, if you have pituitary or ectopic Cushing, you might have bilateral adrenal hyperplasia. This needs time to develop. It might not have that time when you're dealing with ectopic Cushing or paraneoplastic Cushing. You also have to bear in mind the possibility of adrenal incidentaloma versus pathogenic adrenal adenoma. Adrenal incidentaloma is not uncommon problem, particularly as we grow older. And same thing with the pituitary incidentaloma. There's about 10% of population of the elderly population will have a small pituitary lesion that's non-secretory. So we do have to bear that in mind, and don't get excited that we find the lesion. It could be simply an innocent bystander. If you have hypokalemia, or if you're doubting ectopic Cushing, obviously you have to start looking for a source. You have to rule out non-small cell lung cancer, CT chest, and also bear in mind that medullary thyroid carcinoma can secrete ectopic corticotropins. The next invasive modality will be inferior petrosal sampling. Normally the corticotropin gradient should be more than 2 central to peripheral gradient should be more than 2 before we stimulate with the CRH, and more than 3 after stimulation. We do measure the prolactin as well, just to ensure the integrity of canalization of the petrosal sinus, petrosal vein. There are some venous anomalies that could lead to false canalization and subsequently false low results. The IPSS is the test of choice, but it still have false negatives and false positives. As I just mentioned, if it's inadequately canalized, you could end up with false negative result. We do recommend, particularly in cyclical Cushing, that the patient will have a good time to spend with the high cycle of the steroid, because this is most likely going to give you accurate gradients. So in summary, I tend to start with 1 mg dexamethasone suppression test to rule out Cushing disease. If the cortisol suppressed to below 50 nanomole per liter, this is quite reassuring that the case I'm dealing with is not hypercortisolism, with the exception of cyclical Cushing's. If there is any drug interaction that might affect the biometabolism of dexamethasone, I do start my test with a late night salivary cortisol. The other time I go for a late night salivary cortisol would be when I think I'm dealing with a case most likely to be a pseudo-Cushing's. The third clinical scenario where I resort to salivary cortisol is when I have a positive dexamethasone suppression test, and I like to further confirm the state of hypercortisolism with another modality. And with regards to 24-hour urine cortisol, I tend to do it when I have, again, a positive dexamethasone suppression test. It will give us a reinforcement test indication that the case we're dealing with is a genuine hypercortisolism. 8 mg dexamethasone test, suppression test. This is I don't do very frequently, but I want to. But if because of the poor sensitivity and specificity, but it's easier to do if the cortisol suppressed more than 50%. This is likely to be Cushing. If it doesn't, it's likely to be ectopic. And finally, ACTH and DHEAS when I'm not sure if I'm dealing with an adrenal Cushing or a pituitary Cushing, and where the ACTH is not fully suppressed or obviously raised. So this is a summary of my clinical approach to confirm Cushing's.